Hello friends, my live video is starting right now. As per my scheduled program, the video should have started by 8 p.m. but this is for some testing purpose. I have just started it for 5 minutes before the scheduled time. This is for all the settings. If somebody is there, please comment whether I am properly audible or not. Audibility and visibility, are these things perfect? Just a slight nod or a say yes. I would be very much happy if I am audible clearly, so then the actual talk can begin. So if I am not audible, please let me know. That is the very first request. Secondly, as for today's discussion, I have been bestowed with the responsibility of discussing a chapter which is not that very much interesting or nice to go with. There is a chapter on death legalities, the position of COVID-19 in according to the ICD 10, and moreover the cremation guidelines. More or less all the three things, something, it's the gloomy part of affairs, because it's always very much enthusiastic to give a positive picture, give whatever the treatment guidelines, how can we fight. But this part, that is the death certification guidelines, as per the MCCD guidelines, or the medical certification and certification of death, the MCCD guidelines, and the legalities associated thereafter, that is for our physicians, especially the general practitioners who are called at midnight by the local people to issue a death certificate. What are the precautions they should follow? And in this era of COVID-19, what are the added precautions they should take? I would go for discussion on these issues. Apart from that, the most important thing, once again from the public health part, is what is the prevailing standards, what are the prevailing guidelines regarding the cremation criteria. As we all know, now regarding the language, I am sticking to English because I want everybody to understand, even people who are not acquainted with Bangla. But if the request comes at certain areas of my speech, I can also discuss in Bengali, because Bengali is the language I love actually. The thing is, but to begin with, certain terms and terminologies, it's a bit easier to explain in English. So the mode of communication in the initial time, I am keeping it in the English language, but whatever, if the problem comes, please let me know. Definitely no problem with Bangla, because I am very much addicted to Bangla. Whenever the speech comes, the scope of communication comes, I am very much addicted to Bangla rather. But now the very first thing which I am going to discuss, the initial headline of my topic was ICD 10. Now what is ICD? To put on the simpler terms, the coding system is very much prevalent everywhere, in every aspect. That is, every disease is given a unique code in the International Classification of Disease as per WHO, and ICD 10 is a system of giving an unique code to each and every disease. Each and every disease, suppose it be it bronchial asthma, be it COPD, a chronic obstructive pulmonary disease, be it respiratory failure, be it any trauma, everything is given a unique code. Now what the unique change has occurred recently regarding this ICD 10, they are once again classifying this unique code into three types. One is the active phase, or the coded by A, means the initial encounter. That is when the patient is given the active treatment. Active treatment means when the first encounter with the doctor is occurring, they are coding it as A. On the subsequent encounter, that is the first patient comes with a trauma, the doctor is giving a treatment, the surgical treatment, the emergency management. This is the will be coded as A, that is the initial encounter. Then it will come at on the next visit, when the patient is a bit well, he comes to the doctor for a subsequent visit. The subsequent the visit will be denoted as D, A, D, and if there are any complications rather than develop, there is a complication part, they will be coded as A, D and S. So this is the basics of ICD. I won't go into the details because my motto is to discuss mainly on the COVID. Our focus and agenda is COVID now. Now, this is the ICD. This is International Classification of Disease, where every disease and mortality is given a unique code. It's given a unique code, and moreover, the new changes is for the initial encounter, subsequent encounter, and the sequelae. Sequelae for S, the subsequent encounter is coded as D, and the initial encounter is coded as A. So this is the basics of ICD. I won't get into the extreme details because that would be an exhaustive list, and moreover that is not the topic of the day. That is not in the agenda of today's discussion. So secondly, regarding the ICD, what the important thing is, that is for every physician to remember rather, that is COVID-19. COVID-19 is a unique thing which has come. As for all we know that we should not use abbreviations in case of disease. That is a very common thing taught to the final year students. That is, don't say MI. Say myocardial infarction. Okay. Don't say MS. MS means mitral stenosis, multiple sclerosis. So we should not use abbreviations. But COVID-19 is a unique thing. Okay. COVID-19 is a unique thing. We can use the term COVID-19, and as per the ICD coding, COVID-19 is given a unique code known as U07.1 and U07.2. 07. That is a very easy way to remember. That is James Bond 007. So that's something like this U07. Just joking, but the thing is like this, that 7.1, it actually denotes U07.1. It means the case of COVID is confirmed. How it has been confirmed? By RT-PCR or rapid antigen test. The confirmation is mostly for the TrueNat or rapid RT-PCR. So when the case is actually confirmed on the basis of laboratory testing, we go in favor of the 7.1, U07.1. This is the ICD coding. And when it is not confirmed, one is the case or proven case, and another is the probable or suspected case. Now, when you call it probable or suspected case, it means that the patient is having COVID-like symptoms, but however, it is not confirmed by the laboratory testing. That is what commonly happens when a patient gets admitted with fever or respiratory illness, respiratory distress and it's commonly placed in the isolation ward. So till the reports come, the confirmatory reports come, it is a suspect case. Now, if this coding has to be done after the laboratory report comes to be positive for COVID, it is U07.1, and till the report is not positive, or if the patient dies before this laboratory procedures can be done, the laboratory test is confirmed, or even the laboratory test has reached the doctor, if the patient dies, till then the coding has to be U07.2. So this is the basics about ICD coding. I have discussed about what is ICD, International Classification of Disease, and how different diseases are coded. And as per the ICD is once again the initial encounter, the subsequent encounter, and the sequelae. That is coded by initial encounter A, first encounter A, subsequent encounter D, and the sequelae as per what I said is S. So that is the basics. And moreover, this COVID-19 is given the code in ICD-10 as U07.1 when it is confirmed case, and U07.2 when it is a probable case. As per that would not be relevant if I just want to touch a bit of it, that there is another new coding known as ICD-10 and this is ICD-11. In ICD-11 there is a new coding has been done, and here COVID-19 is actually given the terminology RA01.0. when it is a confirmed case RA01.0, and when it is a probable case it is RA01.1. Now getting into the actual part of the discussion, why on the earth somehow someone is actually discussing these things, why on the earth doctors will spend their precious time to listen to these things, and why on earth common people will listen to these things. So this is the very common point of discussion. Why are we at all discussing these things? Now that is here the relevance starts. That is, mortality data. Mortality data are very important data by which we can actually judge the progression of a disease, the killing power, the lethality of the disease, and what are the effective measures to be taken by the authorities, to be taken by the government to combat the disease. So for all these purposes, this mortality data plays a very important role. Now how mortality has to be reported? Now the problem was like that initially when somehow, just getting a bit on a personal note, when we were actually students, writing the death certificate actually meant writing the cause of death. But at a present scenario, the MCC demands that the doctor should write the death certificate in such a way, such a manner that it can be used as a statistical purpose for epidemiological purpose. That is, we want to know the immediate cause, the immediate sequence which actually led to death. We want to know the underlying cause of death, and we also want to know some secondary causes which were prevalent and which may also actually enhance the process of death, but they are not directly the underlying cause of death. So I will explain in details because this statement has become a very long statement moreover. Now the thing goes like that. Now just getting into a history for one or two lines, just one or two lines, not to bore you much. In December 2019, an outbreak of respiratory disease associated with novel coronavirus was reported in the city of Wuhan in the Hubei province of People's Republic of China. The virus spread worldwide on March 11, 2020. The World Health Organization declared coronavirus 2019 a pandemic. The first case of COVID-19 in United States was reported in January 2020 and the first death in February 2020. Now, what is the significance of all these data? Sir, why are you reading out these things to us? The thing is because for COVID-19, I just want to show you the progression. If you don't know when to write a COVID death, there are a lot of confusions. That is, there is comorbidity, it is not COVID. So these confusions were prevalent because it is a new thing which is just propped up from the blue and everybody was confused. So now whenever there is utter confusion, it's always best for us to go with the WHO guidelines, ICMR guidelines from a known and established body. That is, now the thing is that what we are trying to emphasize about the mortality surveillance. Mortality surveillance provides crucial information about population level disease progression. That is the most important thing. If you don't do a mortality surveillance, morbidity surveillance is a indicator, but if you don't do mortality surveillance, you won't understand the lethal power of the disease. Any disease, that is not only COVID-19. Even if we want to make a statistical survey of what is the lethality of any particular disease, be it a non-communicable disease like cancer, be it a non-communicable disease like myocardial infarction, or be it a communicable disease like even a sort of type of diarrhea, we need to have a clear knowledge of the mortality surveillance. Now, that is why, because we are very much interested in the mortality surveillance, so that is becomes the onus of each and every physician to have a clear idea of how to write a death certificate. Now, for death certificates, actually, this is the pro forma. Actually, I don't know whether it is clearly visible to all of us in this screen or not. Not possible, rather. I would actually request every medical student or medical people who are watching this to have a medical certification of death, MCCD 4 and MCCD 4A downloaded from Google in their mobile, because that will always help them in the long run to avoid missing of the essential points. But to get a clear idea about what is the purpose of death certificate. Previously, the purpose of death certificate had been to declare the death, so that the death means termination of the life, death means ceasing to exist. As per the forensic definition, death is complete and irreversible cessation of three interlinked vital systems of the body, namely the respiratory, circulatory and the nervous system, that is coma, syncope and asphyxia. In accumulation, it results in death. Now, so writing cardiorespiratory failure as the cause of death simply, all cases is commonly cardiorespiratory failure, because if the cardiac functions and if the respiratory function goes on, we can only certify brain death rather than. So cardiorespiratory failure is a common term, but what is actually required is for statistical purpose, for the epidemiological purpose, and what should be written is we want to know the actual chronology of events. Actually, we want to know the series of events, lethal events, and even the lethal period. So the thing goes like that: cause of death reporting. When reporting cause of death on a death certificate, use any information available such as medical history, medical records, laboratory test, autopsy report, or other sources of relevant information. So whenever you are going to write a cause of death, that is even in a hospital, even when a physician actually visits in a domiciliary visit, a home visit, when death has occurred in home, it's a very common obligation for the general practitioners. People call them and just request them to issue the death certificate. Then what are the prerequisites? What will they actually? Definitely, if we want to do a thing, we need to have a checklist, 1, 2, 3, 4, 5. We just go for the checklist, okay, whether there is any foul play, why the death has occurred, who is reporting, have I seen the patient early, inspecting the dead body. All this comes into criteria. Everybody of us know that because we see first of all what is the common way of declaring the death. We see that whether the corneal reflex has actually present or not by just inserting a small twig of cotton. We see whether the light reflex is present or not by with using the torch, or even nowadays doctors use mobile light. But probably so. Then we go for the deep pain stimulus with pin prick, or even using our knuckles, deep, whether the patient is responding to pain or not. We look for the pulses to look for the circulatory system. So we examine all the three vital systems. We look for the nervous system by the corneal reflex and the light reflex. We look for the pulse, the circulation. We even use our stethoscope to auscultate the heart, and we also go for the respiration. We also want to look for the respiration by actually looking at the chest, whether there is movement of the chest. We also look for the respiratory sound. So all this commonly we do while certifying death. But what will be the criteria when we found the patient is already died? That's a very common dilemma once again for the doctors. So I am coming back to it, but the very first important things which we should know about the death certificate is three important systems. That is the certificate. Regarding for certification, the most important things, if we see the medical certification, I am starting with the form 4, that is for the institutional deaths, and form 4A is more or less the same, the criteria, but it's for the non-institutional deaths. For the institutional deaths, the thing is like that. Once again, at the very beginning, name of the hospital, I hereby certify that the person whose particulars are given below died in the hospital in ward number on certain date and on the time of death. So what we actually emphasize when we teach our students also, that always never forget to write the name first, who has died. Even if the name is not known, go for the unknown, because sometimes such disaster may happen that we write death certificate, we forget to write the name, we forget to mention the age, we forget to mention the sex, we forget to mention who is the person's immediate kin, that is care of. We forget to mention the residence. All these things matters. If we actually just forget to mention this, the patient party will face harassment. So there should be a checklist and criteria for us, and at present time it is always better to have a checklist and the document with us. For the mobile apps it's very easy for the document. So we are just getting into the actual contents of the document of this certificate now. There are actually three things: immediate cause, antecedent cause, and other significant contributions to the death not related to the antecedent cause. Now what is the immediate cause of death? Immediate cause means that is actually the event which caused the death. Now suppose suppose a patient has died of pneumonia. Just taking into the case, patient has died of pneumonia. There was an underlying pneumonia. The patient had hypertension. The patient even developed had previously been treated for renal disease, and the hypertension resulted from that. So there is kidney disease, there is hypertension. The patient was diagnosed with breathlessness and respiratory distress. He was having pneumonia. Apart from that, the patient was admitted in the institution, and the patient died from respiratory failure. Commonly it is type 2 respiratory failure, because due to the increased carbon dioxide accumulation. Despite all the resuscitative measures, the patient passed. Now, how to write the death certificate? Now, what is the immediate event which actually led to death? That is the respiratory failure component. That should be written in this. If it is visible, that is should be written in the immediate cause. This immediate cause part. Immediate cause should be the actual event which has led to the death. That is the respiratory failure part. But what is the antecedent cause? What actually led to this? What is the underlying cause of death? That is the most important thing. Underlying cause of death. Now, in history, if they have, the patient has having hypertension, the patient may have chronic obstructive pulmonary disease, the patient is also having a renal failure. So, the renal failure may lead to the generalized debility, and the patient may become more susceptible to infection. Similarly, this chronic obstructive pulmonary disease, COPD, also makes the patient susceptible. Do you really think that this is the main offender which led to this type 1 respiratory failure? The patient is having COPD, so he has type 1 respiratory failure. Okay, this COPD, hypertension, renal problems, all this led to the susceptibility of infections, but there is some bacterial infections which has appeared as the main culprit leading to the type 1 respiratory failure. So this bacterial infection, or suppose this is a viral infection now, COVID-19, which has come into play. The patient is diagnosed due to COVID-19. Now, if respiratory failure becomes the immediate cause of death, then this pneumonia and the pneumonia and also the COVID-19, these things will come in the antecedent cause. Now, what about this renal failure and what about this COPD? Now, as per the CDC guidelines, there is actually a dilemma, because many doctors may argue that okay, because this patient is having the COPD, he developed the infection, and because of the infection he developed the pneumonia, and also the hypertension was present, so the body immunity went down, and that's why it terminated in the respiratory failure. Okay, that's a clear guideline, but as per the thing CDC, they are actually saying that you just first identify the sequence of events. Because the patient is having COPD does not make the patient actually die from pneumonia. But the thing is, COPD is making the patient susceptible to infection. So this is the secondary cause of death. That is appears in the part 2. The part 1 has two important definitions: immediate cause, antecedent cause. Immediate cause means what actually caused the death. Ventricular fibrillation in myocardial infarction. That is the immediate cause. Septicemia, multi-organ failure, immediate cause. Type 2 respiratory failure, type 1 respiratory failure, even respiratory acidosis. So these things actually leads to the immediate cause. But what is the underlying cause of death? That is the infection component, the bacterial infection, the septicemia. And in case of COVID-19, if COVID-19 is positive, If COVID-19 is laboratorily confirmed, we can go for a diagnosis of COVID-19 in the antecedent cause. So that is the question of comorbidity. Comorbidity can jolly well be there. Even it can be a malignancy can be there. Now suppose it is a malignancy also, diagnosed with COVID-19. Now once again, that is the thing is COVID-19 will come under antecedent cause. Why? Because malignancy was there, but if any oncologist is actually watching me, he will definitely, even all our doctor friends will definitely agree that apart from the malignancy actually lowers the body immunity, and the treatment also sometimes adds on to the lowering of the body immunity. So if now a person gets an infection, be it a tuberculosis infection, be it a viral infection, so the sequence of events, the viral infection will becomes more important than the underlying cause of disease. So once again, the viral infection or the bacterial infection comes under the antecedent cause of disease. So this won't go in the part 2, that is this won't go into the other significant conditions contributing to the death. The COVID-19 or the viral infection will come under the antecedent cause. So that's the point I am trying to clarify. In this actually live events, it's a bit difficult because I can only watch your comments. The thing is like if I am actually clear or not. But that is the point I am trying to emphasize. That what is the extent when if it is a comorbidity to the extent of an advanced carcinoma. So if there is COVID-19, would this death be termed as a COVID-19 death? But the thing is that once again the decision is upon the doctor. But if the thing is COVID-19, we can say that the immediate cause of death is be it a respiratory failure, be it a septicemia, be it a multi-organ failure. But if COVID-19 is there, it will come under the last line on the antecedent cause. So that is actually expected, that is the way of reporting. I am actually quoting the CDC, WHO guidelines. And our country also follows this guideline. So that's why I am emphasizing these parts. So this is how it goes about the legalities of certification. Now what will happen, the most important thing on the public part, what will happen if a patient diagnosed with COVID-19 who is living separately in a quarantine, he was isolated himself and unfortunately a death event has occurred. What will happen in COVID hospital if a death has occurred? I am coming to it later. But the most important thing, what actually makes people very much worried, that if such things happen, that it's very fortunate that most of the people diagnosed with COVID-19 are doing very well, they are recovering. But what happens in case of an untoward event? The sequence is like that. The people who is diagnosed to be positive by RT-PCR, they should keep the phone number. Actually, the civic bodies calls them. In West Bengal, the scenario is very good. The civic bodies calls them. So if we have the number of the civic bodies, the public, local governance, if we have the phone numbers even of the local police station, if such incidences occur, they should contact them, and the civic authorities will actually take the measures to actually bring doctors for writing the death certificates and the subsequent events. But what happens if a general practitioner is called for the same? Once again, his responsibility then becomes to, if the patient is known to him and if he feels that there is no foul play that has occurred, then he should definitely, the patient is known to him, there is a documentation that there is COVID-19 and the doctor feels that the death has occurred. But now there is a catch once again, as per the prevailing previous guidelines. The thing was like that, if the patient is not known to you, you are seeing a dead body directly, then it's a bit difficult to directly issue a death certificate. So once again, it's better if you are seeing the patient for the first time and when the patient is actually not responding, the writing death certificate is once again a bit problematic. But now in this present scenario, if such untoward incidents happens, the relative should consult the civic bodies, the local authorities, and they should consult with the doctor. So if there is documentation that the person is COVID infected and because of the COVID the person has died, if there is a documentation, then and if there is no, even the police can inquire if there is any scope of foul play, because it always has to be inquired, so it has to be actually excluded. So if there is no foul play, death certificate can be issued, because we don't want to issue death certificates in case of we don't want to actually do postmortems in case of COVID-19 deaths, because actually as per the guidelines, which I will come later, I will come soon, cremation guidelines. So if there is no foul play involved, and if it is the COVID-19 death, so it's better not to go for the post-mortem, because a death from COVID-19 is a natural death. It's not suicidal or homicidal or accidental. The catch is, once again, if somebody of COVID-19 actually gets killed in an accident, falls from height, or actually commits suicide, that's something different. Then it has to be decided. But that I am coming to later. But the thing is, for up to this purpose, when the death is natural, when there is no foul play, death certificate has to be issued, and the local civic bodies has to be contacted by the public, by the people. And as per the civic bodies, when there is, it's the municipality area, it's municipality, it's panchayat, it's the panchayat, and it's the corporation area, it's the corporation, the councillor, and the people has to be contacted. Even the government officials can be contacted who are entrusted for the purpose of that area. Moreover, the people also can contact the public people's representatives, the police. So help will be available for that. Now, if death occurs similarly in the COVID hospital, once again the COVID-19, if the patient is actually diagnosed to be COVID-19 and the sequence of events is like such that the patient is diagnosed and thereafter he developed illness, respiratory distress, so the cause of death has to be certified as per so. Once again, another important cause is the lethal period, that is to be reported. The lethal period is the time from the onset of the terminal events to death. So time period from the onset of terminal events to death is not the lethal period, and it begins, suppose it begins with the fever, influenza-like illness. It may begin with a respiratory distress. So this, from that time till the terminal event, it is the lethal period. Most of us don't quote that, but it's better to quote because it will help us for the epidemiological statistics. Statistical purpose, epidemiology. And if epidemiology, public health works well, definitely we can combat with a disease with a much greater involvement, with a much greater knowledge. So whatever this proposed death certification is not only a legal step, but is also a scientific procedure we are doing for the benefit of mankind at large. Now, regarding the accidental deaths, as we all know, for accidental deaths, unnatural deaths, any deaths which are not natural, we have to go for autopsy purpose. Now, unnatural deaths means death is not natural. What is natural death then? Death solely from diseased or pathological condition where death is not intended, attempted, or accidental. These are the natural deaths. And sudden death, another common terminology known as sudden death. Sudden death actually means that death of an apparently healthy individual within 24 hours of onset of terminal illness, when the cause of death cannot be determined by the doctor. There is a suddenly the person dies, falls and dies. So it's once again this autopsy part. Now, regarding the autopsy part, now I am coming to my second part. That is the second part of my discussion, the cremation guidelines. So we knew that the very previously everybody was very much concerned when the patient of COVID died. That is, we are concerned because the dead bodies, how they to be disposed, all these things. So even certain, we all came across a story that a doctor probably in South, his body was not allowed to be the people actually cremated, and people actually used to pelted stones at the people who went for cremation. These things happened. So there was actually an area of this total confusion. Now the thing is like that, though it is not actually totally established, but the thing is like that, the chance of spread is more from the people who are actually breathing, because this virus spreads from aerosol. But when there is less chance of aerosol generation, mostly from dead bodies don't breathe. dead bodies don't cough, dead bodies don't sneeze, so they don't spread aerosol. So it's the chance of spreading infection from aerosol is much less. So actually this undue fear of dead bodies dying of COVID in patients, that is, they won't be allowed to be cremated, there are all the people creating problems for cremation, that is not a good thing. As per the guidelines, the bodies has to be, all the indwelling catheters, the IV lines has to be removed and put into the disposable vat for removal. The body has to be properly packed with a plastic bag, and all the orifices and all the open wounds has to be drained with, has to be dressed or plugged with hypochlorite solution, 1% hypochlorite. So that is sufficient. So actually what my personal view is, and also the guidelines suggest, that if the undue fear of COVID-19 dead bodies is not such rational, and there should be propaganda against it, that people should get the last respect. This COVID-19 deaths can even happen to me, can happen to anybody. So the last rights, the last respect. So now I am coming to the cremation guidelines. That's very important, because I would like to emphasize these things, what I am trying to say regarding the last part of my speech, that is I am not just reading out the entire thing, but that is very much available in the net, cremation guidelines, WHO cremation guidelines. But certain points I would like to explain properly. One is the transportation, how the body is to be transported. The body is secured in a body bag, exterior of which is decontaminated, no additional risk to the staff transporting the body. That is, the body has to be packed in probably a plastic cover bag, body bag with a zipper. So even if there is a chance of fomite-based infection, that remains concealed within the body. The person handling the body may follow standard precautions, that is surgical mask, gloves, goggles, if they have these things. The vehicle after the transfer of the body to cremation burial staff will be decontaminated with 1% sodium hypochlorite. Now this sodium hypochlorite, actually I don't know whether I should confidently utter this thing, but a cheap alternative is also bleaching powder, solution of bleaching powder freshly prepared. It works the same. So actually for this decontamination of the larger vehicle or something, if this sodium hypochlorite on that extent is not available, it's always better to go with the guidelines. Sodium hypochlorite, if not available, bleaching powder can also be used. Okay. And another important thing, though we are saying that this virus, the use of mask and protective surgical gloves and also the goggles is very important. And apart from that, cleaning the surface areas with bleaching powder, and as per the guidelines, sodium hypochlorite is very much effective, especially in case of dead bodies, because people must get the last rites, because actually it's our born right. We must actually have some dignity while we leave the world. Now this is the crematorium burial ground guidelines. The burial ground staff should be sensitized that COVID-19 does not pose additional risk. We should make this propaganda, because apart from science, humanity matters, humanity matters, humanity matters. If we just strike off the humanity component, people with science only, they will experiment on people then rather. The humanity matters. So that's the point I actually want to emphasize, because if we don't, it's the term was coiled as social distancing. That should have been physical distancing. Social distancing doesn't mean we won't help our people, we won't help our neighbors, we won't help people who are affected, we won't help people who died from COVID-19, because our own family members can also be the victims, so nobody will come to our help then. But we definitely should follow the guidelines. The crematorium burial ground staff should be sensitized that COVID-19 does not pose additional risk. The staff will practice standard precautions of hand hygiene, use mask and gloves. Now the most important thing, viewing of the dead body by unzipping the face end of the body bag may be allowed. So that's the very important thing. Somebody's own relative has died, somebody's near and dear ones is leaving him for the last time. So if he wants to look at the face for unzipping, we should have a human face. Religious rituals should be allowed. Religious rituals like being chanting the mantras, the sprinkling, this sprinkling of holy water, this can be allowed. But actually, physical touching, kissing the body, hugging the body, physical touching, bathing, all these things is not allowed. Okay, because that's once again a emotional component comes there. When the near and dear ones actually living the last time, people may feel that urge to touch the body, to have a last pranam. But the thing is like that, this thing is actually not allowed as per the guidelines. So this distancing has to be maintained. Physical distancing must be maintained. Now, the funeral, burial staff and family members should perform hand hygiene. The ash does not pose the last, when the Hindu brothers, the burning has occurred, the ash does not pose any further risk. So that can be collected for the last rites. That is once again I am talking of the emotions. We should respect the emotions. If it is not spreading the disease, because when the WHO is saying that it is certain things which are not infected, we can be afraid and shoo away people from us. There should be community participation, because whenever there is a problem, we want to overcome the problem together. There should be community participation. Only uttering science and only uttering such books, studies, that doesn't actually heal the world. If we want to heal, we should hold hands. We should hold hand the health of health workers. We should hold the hands of the first line defenses of this front line workers who are actually fighting the infection, and also we should be together even with the common people. Now lastly, actually I am at the fag end of this thing, because whatever be it, even despite my best efforts, I couldn't make this topic very much interesting, because certain facts has to be discussed. Now regarding the autopsy guideline, once again, autopsy should be avoided as far as possible. As far as possible, autopsy should be avoided in case of COVID-19 death, if it is natural death. But if it's to be performed, suppose it's a unnatural death. Unnatural death means suicidal or homicidal and confirmed case. Now what is to be done? Then it's a dilemma once again. As per the guidelines, the autopsy should be done with the proper precautions. That is the very first thing. Wearing the PPE, the number and forensic experts and support staff in the autopsy room should be limited, minimal. The team should use full complete PPE. Now PPE is available more or less at least in our state. Coveralls. If somebody wants to refer, they can say sure, but I am telling my observations. Anyhow, always when you go for a live, when you discuss, certain things comes which is actually own observation that can definitely differ with other people. Now this full PPE, that is coveralls, head cover, shoe cover, N95, mask, goggles, face shield. Now round-ended scissors, all these things has been mentioned, but the thing is like that, we should go for minimal aerosol generation when not needed. And the thing is like that, the lungs of the COVID-19 patient has to be handled carefully. That is the important thing. Even the procedures which generate aerosol, like opening the skull, that has to be done with a precaution, because that leads to some aerosol sprinkling. So the standard protocols has to be followed, that most people follow. We actually follow these things. Even the thing is that for the doctors who are actually doing the autopsies, they should also, not only for themselves, but also the health workers, the mortuary attendants who are attending, they should enforce that these people also follow the precautions, because if one is affected, chance of spreading is more. So once again the thing goes like that for community participation. And the most important thing what we really teach to all our students, needles should not be reseated after fluid sampling, reduce aerosol generation during autopsy using appropriate techniques. Embalming of the dead body should not be allowed. Now, embalming means when you want to transport, that embalming means when you want to preserve the body. Suppose the body has to be transported in another state, we use the formalin to preserve the body. But now it is not allowed. Especially now it is not allowed in case of COVID deaths. COVID death body embalming should not be allowed. Now, standard precautions to be followed by health workers handling COVID body. Once again, using the proper PPE, personal protective equipments. And the thing is like that, every health worker should have a basic training of infection control. This is important because proper hand washing, proper hand hygiene, using the mask, wearing the proper technique of using the mask, these things has to be discussed with the health worker. With even the health worker, even to the extent of the people who are actually in the cleaning purpose in the mortuary, we should have a talk with them, because once again the thing comes, community participation. Together we stand. In the very first COVID era, the things were coming that we don't stand together, just stay aloof, that is. But community participation should be there. We should talk to people. There should always be that scope. For environmental cleaning and disinfection, once again, the floors, bed, railing, side tables, IV stand should be wiped with 1% sodium chloride solution. Allow a contact time of 30 minutes and then allow to dry. So this sodium chloride, 1% sodium hypochlorite solution is a very good thing. If not available, then bleaching powder can be an alternative. As per I should talk about the guidelines only. Guidelines is 1% sodium hypochlorite. It is also available. Also bleaching powder works. So till this much, this is my discussion. I don't want to elaborate it much because people will get bored. Till now, this is the discussion. And another important thing I want to tell to all more, share with all people, persons who are watching for this WHO CDC, there is actually a mobile app, cause of death mobile app. It's available from http www.cdc.gov. NCHS, NVSS, mobile app. There is mobile app cause of death available from www.cdc.gov. So if anybody wants to have this app, you can jolly well have it in a mobile. That would be a very ready reckoner for it. So I am at the fag end of my discussion. If any questions on your part, we can actually have a discussion. Otherwise, I have tried to elaborately and lucidly describe the different aspects immediately of firstly the international classification of disease, to summarize international classification of disease, then the different types of codes of COVID-19, then we discussed then we discussed this first, the ICD codes have three parts. There is the before sequelae and complication, the first interaction, code A, code D and code S. Then we went for the U07.1 and U07.1 and U07.2, that is the coding of COVID-19 as per the ICD, that is the established disease U07.1 and the probable cause U07.2. Then we went for the how to write death certificates. Then definitely actually one thing in death certificates, this institutional death, the last part has to be handed over to the patient party. Rest part remains for the statistical purpose. For non-institutional delivery also, the non-institutional death certificates writing also, this last part has to be delivered to the patient. This is by the physician for notification purpose. And as per most of the general practitioners has to do this thing, that they have to write on a pad death certificate. But if this thing, it's always better to have a printed pad as per the MCI medical certification as form 4A, because it will help it as a cross-checking also. Because everything is written, whether PM is required, whether she is pregnant, whether pregnancy is a cause of death also. Then there is also age at death, sex, all these points are clearly mentioned. So that it will act as a checklist. Okay, then the timing of death, all these things are written. If these things are not written, you are missing an important clue. And it may also cause harassment to the patient party if you forgot to write any important part. So this printed form always helps rather than thinking from mind and writing, because you may miss an essential diagnosis. Male, female, if less than 1 month in age, if less than. So this thing, what I would advise every my doctor friends, that get a printed copy and keep a printed copies of Form 4A for who are actually practicing. When you need to write these things, it's always better to follow the protocols. Now, before ending, actually no such questions is there. Before ending, 2 or 3 points. I tried to stick to the subject at the most as possible. Some of my personal opinions came because that is very human nature. When you want to talk something about any subject, some of your personal observations comes, and most of my talks are based on the health standards which are finding in West Bengal, because right now, as per my individual observations, the thing is we are actually coping with the things better than the initial periods. So, thanking you all for watching, and the part of the discussions today sadly has become more doctor oriented, because I want to actually spread this message to every practicing physician to what is the MCCD and what is the proper, because many a time still I find that people ask the cardiorespiratory failure, but okay, cardiorespiratory failure is okay, but the thing is like that, if we can actually still write the cause as per sequence, because that is the need of time. And even for this COVID-19, when to write COVID-19, what are the comorbidity rate of COVID-19, these are all these form of confusions which are prevailing. If we go by this criteria, we would always land up in a correct line. Okay, so this is as per my discussions for today. Thanks for watching. To all my physicians friends, take care. To all my health workers and to all my friends outside the medical arena, take care. Practice physical distancing, practice safety norms, and help your neighbors, help your colleagues at times. Thanks a lot.